So shall we start?
Yes, please.
Thank you everyone for joining us. I would now invite Mr. Manoj Kumar, Senior Vice President of Intas Pharmaceuticals, to please say a few words. Over to you, Mr. Manoj.
Thank you very much. I just wanted to say that I have never ever heard a topic of this kind. So I'm here to welcome all of you and just learn from the wisdom of Dr. Purvish Parikh. He is famous for pulling off something which is incredible and differentiating and path-breaking. I would also like to welcome all the foreign delegates. Namaste from India, Dr. Vivek Agarwal, all Dr. Bapna sir. I think all of you guys are making all of us at India proud that even during this COVID time, innovation has not been lost. So over to you, Dr. Purvish Parikh. I'm here as a student.
Thank you very much, Manoj. And I think the honor should go to Vivek, who's worked so hard. So, Vivek, I will pass on to you for the setting the ball rolling for this series one.
So before that, can I introduce Dr. Vivek Agarwal, who's our
Of
honorary
course.
secretary and of the Asian Cardio-Oncology Society and the medical oncologist from Kolkata. Over to you, Vivek, sir. Vivek, sir, you'll have to unmute your mic.
Yeah,
Yeah,
just a
okay.
second. Yeah, I'm unmuted. I think I'm muted from your side, Kashif.
So no, so you're unmuted. Sir,
Yeah,
your
yeah.
screen sharing has been unshared. So you have to
Okay,
share
yeah,
your
yeah,
screen
yeah,
again.
yeah. Yeah, so sorry for that glitch. So, a very warm good evening to all of you. Myself, I'm Dr. Vivek Agarwala. I'm a practicing medical oncologist at Narayana Super Speciality Hospital, Kolkata. And today, on behalf of the organizing committee, I welcome all of you to the Asian Cardio-Oncology Society inaugural conference series. Dr. Purvish is our program chair, and Dr. Susan Dent is our program co-chair. She hasn't been able to join today due to certain prior commitments. Dr. Ajay Bapna is our co-organizing secretary, and myself, I am the organizing secretary. So we are facing very tough competition because IPL has already started. It's like a craze in India. And there are so many webinars. Everybody is just too tired of webinars. But against all these odds, even at a short notice, I see that there are so many participants today. So I think we are doing good. And I really thank you again for joining. Well, I would have loved to really be suited, booted, and address you physically today in a meeting. But the whole world is grappling with this coronavirus pandemic, and it wouldn't be really correct to call it a blessing in disguise. It's such a curse because so many people have lost their lives. So many frontline healthcare workers are being affected. Our sincere condolences to all of them. But if it would not have been due to this COVID crisis and this virtual conference era, probably at such short notice, we wouldn't have been able to really put up this program for you with all these foreign delegates and speakers included. So, only because of this virtual thing, probably we are able to do this. For somebody who like me, who was so ignorant of this topic of cardio-oncology a few weeks ago, I think each and every day has been a learning step for me since we set out to really carve this program out and this forming this society. So we know that all steps, small steps that we are taking in the present probably are going to lead to a big success in the future. And no matter how the big or small the success is, probably it's too early to call it a success. But I'm really happy to see how it is shaping out, and we are really hoping to build upon what we have started. So how it started, basically it all started 2 months ago in July 2020 when I was being invited to moderate a panel discussion on cardiotoxicity in oncology. And at the same time, I was also looking to publish one of my case reports on cardiotoxicity. And then I really started researching on this field, and this idea cropped up that really we should do something in this field of cardio-oncology, because this field is somewhat lacking in the whole of Asia as well as India. And what we realized over the course is that there is an international cardio-oncology society, and it was formed way back in 2009. They have a journal of cardio-oncology which is dedicated to this field. And this society, they have been working to improve the lives of patients through research, through education, and through care in this field of cardio-oncology. There is a yearly cardio-oncology meeting that they are holding. Of course, this year they are holding on a virtual platform on the 1st of October. So really trying to understand what this cardio-oncology is all about. So we all know, as an oncologist, I always knew that almost all classes of anti-cancer drugs do cause some sort of a cardiotoxicity, ranging from arrhythmias and myocardiopathies to arterial and venous vascular disorders, pulmonary hypertension, systemic hypertension, pericardial diseases, and valvular heart diseases. And we have been dealing with this so much. So but then why cardio-oncology? You see, anti-cancer drugs have hepatic toxicities also, but we don't probably have a branch of hepato-oncology. They have pulmonary toxicities, neurotoxicities, skin toxicities, kidney toxicities, but we don't really, I don't think, I really don't know if they exist, but I don't think there is any branch of pulmono-oncology, neuro-oncology, or a dermato-oncology as important as cardio-oncology, because we certainly do realize that probably cardiotoxicity is something that is the most concerning among all toxicities. And we must also realize that cancer and cardiovascular diseases are the two most common causes of death and disease all over the world, and more so in Asia and India, because of the increased high population in the region. Obviously, India being the capital of cardiovascular diseases, as well as the capital of cancer, with the highest number of cases contributing to the global burden. And with increasing age and increasing life expectancy, we are only going to see more cardiovascular diseases and more cancers. And with better cancer control and cure, we are going to have more cancer survivors. And of course, they would be having more cardiovascular diseases. And in any cancer clinic that we see, maximum patients are actually already having cardiac morbidities, or they will be developing the cardiac morbidities. So definitely we need the cardiologists and the oncologists to work together, and that is why we need this branch called cardio-oncology. What is cardio-oncology exactly? So it is nothing but coordinated care and a truly team effort of cardiologists and oncologists in order to prevent and treat the cardiotoxicities during or after cancer treatment, and to ensure that there is a healthy heart and continued cardiac care while we continue a potentially cardiotoxic anti-cancer treatment, in all together achieving better overall outcomes for our patients. But the problem that we have at hand is that cardio-oncology team is lacking in most Asian countries. And when we really ask oncologists regarding what is the perspective of this problem, their side, so if you ask any oncologist, if you ask my perspective as an oncologist, so do I really believe that my cardiologist actually understands my concerns regarding the scope of cardiotoxicities of anti-cancer treatment beyond anthracyclines? And I think for most oncologists, the answer probably would be no. We know that there are subtle echocardiographic changes which need to be reported. Most cardiologists know it, but if you look at any echocardiography report, it is not reported differently for cancer patients at most centers. We don't have universal reporting. And there are only a very handful of centers in Asia who have dedicated cardiologists for cardio-oncology clinics. When you ask a cardiologist on his perspective of this problem, so of course, we have a joke regarding plastic surgeons. So, we say that a plastic surgeon is only concerned about his flap. It doesn't matter to him whether the patient is living or dying. What all is matter is just the flap. So this is the same way, probably the cardiologists think about we oncologists, because probably there are many oncologists who are only concerned about the cancer treatment outcome, but really they are not concerned about the long-term cardiovascular issues of cancer treatment. There is some sort of a tunnel vision that oncologists do have. And most cardiologists would also say that we would go to our cardiologist whenever we have acute events, and sometimes we do take their clearance or their reference when we are wanting to start treatment in patients who have cardiac comorbidities. But rarely do we involve the cardiologist during the follow-up, during our treatment or after the treatment. And that is where the role is in order to prevent these cardiac events. And the real issue is that whenever we are offering these solutions as better monitoring, better cardiac monitoring, better cardioprotective measures, so is this all cardio oncology effort going to save lives for us? Is it going to prevent a fatal cardiac event? This is the real question. And if yes, then how is it going to, when we should intervene? We all need to know this data. And if it is not going to prevent these cardiac events, then we of course need to sit together and think what more we can do. And definitely we need more research in this area. There are pharmacogenomic and ethnic variations in Asians, and again the data is lacking from Asia. So I think the time was right that we got together to come together as an Asian Cardio-Oncology Society. Many thanks to Dr. Purvish as well as Dr. Hisham, because we three together really took great efforts to make everything come together. I think I was talking every day to Purvish sir for around 30 minutes daily since last 4 to 6 weeks. So in order to make this event happen. A special thanks to Dr. Arjun Ghosh, who is agreed to be our international advisor. He had connected us to a lot of faculties outside India to really get this thing going. And a special thanks to our keynote speaker today, Dr. Jun Chong. She agreed to be the keynote speaker today at very short notice, and she's agreed to be our Singapore representative. So many thanks, madam. Um, of course, we have proposed, and we are on the verge of forming this Asian Cardio-Oncology Society. And our aims are mainly to promote cardio-oncology among the cardiologists as well as the oncologists, to guide establishment of cardio-oncology clinics, to promote research in this branch, to bring out certain consensus documents to promote universal practices with regards to cardio-oncology. For example, as I just mentioned, a universal 2D echo reporting protocol for cancer patients, and of course, international collaboration for training and fellowships. A little bit regarding this society. So we already have the website formed. We are working on it to make it functional as soon as possible. We already have a dedicated email. We have our social media handles working. We have a WhatsApp group. There are already 35 members registered in this society, and the formal registration of this society is under process. And I invite everybody that you all have a golden opportunity to be a founder member till 1st of October. After that, we will be having a general body meeting of all our registered members on the 4th of October to really get things going forward. Regarding our international collaboration, I just mentioned regarding Dr. Arjun Ghosh, who agreed to be our chief international advisor. Dr. Susan Dent has agreed, and contributed a lot to co-chair and shape up this conference series. Dr. Alok Khurana, Dr. Michael Fredley, Dr. Teresa Lopez, they've all agreed to be our keynote speakers at very short notice. Many thanks to them. And we are already in discussion with many cardiologists and oncologists of other countries. The aim is really to truly go international. We are also looking forward to endorsements from ESMO as well as the International Cardio-Oncology Society. Regarding endorsements, so from the oncology side, we already have this conference being endorsed by ICON, by the Integrated Academic Society of Clinical Oncology, by the South Asian Journal of Cancer, as well as the SARC Federation of Oncology. From the cardiology side, it has been really a bit tough to get to know the interested cardiologists, but we have already applied to Cardiological Society of India, to Heart Failure Association of India, to Women in Cardiology and Related Sciences Association, as well as the IJMS for endorsements, and the work is in progress. Regarding this conference, so this is the agenda. We are going to meet every Thursday from today onwards till 5th of November. These are all short meetings of only 90 minutes, which will include our keynote lecture by our international faculty, followed by a panel discussion, and then an interesting case discussion. We have tried to cover as much topics as possible. The real life and published case reports that we will be discussing will make it more interesting, and the faculties are all invited and selected on the basis of actual publications in cardio-oncology. We have done our research in that, so that we try to include as much interested people as possible. And even after these meetings are over till 5th November, our plan is to continue this series of meetings at least with a monthly virtual meeting. So we are looking forward to that. With all that, I thank you again for participation, and over to Dr. Purvish Parikh for taking forward this meeting. Thank you.
Thank you very much, Vivek, for setting the ball rolling and giving the wonderful overview of what we should all expect. I thank all the participants for being here, and now it is my honor and pleasure to introduce our first keynote speaker, Dr. Chong Jun Hua. She is Associate Consultant, Department of Cardiology at the National Heart Center in Singapore, and her clinical interests are all related to cardio-oncology. In fact, she is doing her PhD in clinical sciences at NUS Medical School in cardiovascular medicine. So without wasting much time, may I hand over to our speaker for the keynote address, please.
Thank you so much, Dr. Parikh, for the kind introduction. Thank you very much as well to Dr. Parikh, Dr. Agarwala, Dr. Ajay Ghosh, and the team for this amazing initiative. This Cardio-Oncology Society is definitely very much needed in Asia. It's growing in Singapore, and we're very much looking for, Southeast Asian, ASEAN, and Asia-Pacific-wide collaborators. Definitely an unmet need, certainly in Asia. I'll just proceed to share my screen for the PowerPoint slides. As Dr. Parikh has already mentioned, I am a cardiologist at the National Heart Center in Singapore. I'm also a PhD student at Duke US, pursuing a PhD in clinical sciences, looking at novel telemedicine and pharmaceutical strategies to reduce infarct size. I practice multimodality cardiac imaging as well as cardio-oncology. I completed my cardio-oncology fellowship at Bart's Heart Center under the mentorship of Dr. Ajay Ghosh. I'm humbled very much by this opportunity, and I'm very much eager to learn from the group, from all over the world, oncologists and cardiologists alike, and also look forward to future collaborations. Special thanks also to Dr. Ghosh, who had input and gave many important feedback with regards to the scientific content of these slides. Our objectives today, I'll aim to give an overview of cardio-oncology and give an overview of the risk and types of cardiovascular complications in cancer survivors, provide a framework to manage cancer-related cardiac dysfunction, including in the COVID-19 era, and also touch now, actually in the next slide, on the specialized topics that will be upcoming in the ACOS conference series. As you can see here, our esteemed colleagues will be doing a deep dive dive into multiple various topics in cardio-oncology, including thromboembolism, preventive strategies, 5FU coronary spasm, the cardiotox study, arrhythmias, and also the up-and-coming CAR T-cell treatment and the heart. So cardio-oncology, in my opinion, meets three unmet needs. Firstly, the burden of disease of cardio-oncology is expecting to reach epidemic levels. The number of cancer survivors will rise to 19 million in the US and 4 million in the UK. Here in Asia, we account for about 60% of the world population and half the global burden of cancer. And the incidence of cancer cases is estimated to increase to 10.6 million in 2030. And of these, 70% of these cancer survivors will have a 5-year life expectancy due to advances in early detection and treatment of cancer. So it's good that our cancer survivors are living longer. However, greater than 50% of males and 40% of women above the age of 50 will develop cardiovascular disease during their remaining lifespan. We also need to have optimal management strategies for cardiotoxicity. In this retrospective study, where patients were undergoing anthracycline or trastuzumab therapy were identified, 40% were found to have a decreased LVEF after anthracycline and or trastuzumab treatment. But of this 40% of patients, only 40% received ACE inhibitor or ARB therapy, only half got beta blocker therapy, and only half got cardiology consultation. So whilst the number of cardio-oncology patients are increasing exponentially, so should awareness and availability of optimal management strategies. I put this slide in just to touch briefly on the traditional thinking of cardiotoxicity when the concept of cardiotoxicity first arose with the birth of adriamycin, also known as doxorubicin. It was thought that cardiotoxicity was divided into type 1 versus type 2. Type 1 secondary to doxorubicin, irreversible and high likelihood of recurrence, and type 2 secondary to trastuzumab with a high likelihood of recovery. We now know that this classification is perhaps a little too binary, because we will learn in the upcoming weeks that many different types of cancer treatments can cause many different types of cardiotoxicities. There's also quite a lot of variation, subtle variation in the definitions of cardiotoxicity across standard organizations. So the American Society of Echo and the European Association of Cardiovascular Imaging define cardiotoxicity as an LVEF fall by greater than 10% to absolute EF of less than 53%. They can be symptomatic or asymptomatic for heart failure. The ESC defines it as an LVEF fall of more than 10% from baseline to EF of less than 50%. They can be symptomatic or asymptomatic for heart failure. And certainly with the rise of strain, really we're looking at a relative change of about 15% in strain between measurements. The Cardiac Review and Evaluation Committee for trastuzumab recommends assessing for heart failure symptoms and signs on examination with an LVEF decrease of greater than 5% to less than 55% with heart failure, or LVEF decrease of greater than 10% to less than 55% without heart failure as meeting cardiotoxicity. Also to just point out for everyone to keep a lookout, the British Society of Echocardiography is coming up with their very own cardio-oncology guidelines for which Dr. Arjun Ghosh is the lead, and it will be coming out later on this year. So do keep a lookout for that. And so these, I thought I'll just list the risk factors for cardiotoxicity. They include current myocardial disease, including heart failure, previous coronary artery disease, various cardiomyopathy, demographic factors like age, family history of heart disease, hypertension, diabetes, hypercholesterolemia. So lots of overlap with our traditional cardiovascular risk factors, and also previous cardiotoxic cancer treatment, like prior anthracycline use or prior radiotherapy to the chest or mediastinum, and the traditional lifestyle risk factors like obesity, sedentary habit, smoking, and high alcohol intake. There are several mechanisms by which doxorubicin is thought to cause cardiotoxicity. It is thought now more and more that doxorubicin affects, other cells in the heart, including the smooth muscle cell, cardiac progenitor cell, endothelial cell, and cardiac fibroblasts. And the mechanisms involved are oxidative stress, DNA damage, senescence, and cell death. So the therapeutic effect of anthracyclines against cancer cells is mediated through the inhibition of topoisomerase 2 alpha. Topoisomerases, as we will recall, are enzymes that are involved in the winding and unwinding of DNA. So in cardiomyocytes, topoisomerase 2b is inhibited. Topoisomerase inhibition in cancer and in cardiomyocytes causes accumulation of double-stranded DNA breaks and mitochondrial dysfunction, leading to activation of cell death pathways and accumulation of reactive oxygen species. Now, early cardiac injury can be detected through quantification of circulating troponin, and the protective effect of desoxyribonucleic against anthracycline cardiotoxicity is now thought to be largely mediated through the inhibition of anthracycline binding to topoisomerase 2 beta that's present in cardiomyocytes. While doxorubicin inhibits topoisomerase activity, it enhances the level of HER2 expression in human cardiomyocytes, which may render the cardiomyocytes to become dependent to HER2 signaling for survival under stress conditions. Therefore, in patients that have the 2-hit of doxorubicin followed by trastuzumab, their cardiomyocytes are actually more sensitive to trastuzumab treatment after doxorubicin exposure because of the HER2 blocking effect, thus making the cardiomyocyte unable to regenerate and heal. So why is it important to think of cardiotoxicity and find ways to detect cardiotoxicity early? Well, in this study of 201 consecutive patients with an LVEF of less than or equal to 45% secondary to anthracyclines, enalapril and, where possible, carvedilol were promptly initiated after detection of LVEF impairment. As you can see, the percentage of responders progressively decreased as the time from the end of chemotherapy to the start of heart failure treatment increased. Responders showed a lower rate of cumulative cardiac events than partial and non-responders. Therefore, the take-home message for me from this study is that it's important to think of cardiotoxicity, to detect it, and then to start treatment early. Here is a schema to think of how to approach cardiotoxicity. So at the start of chemotherapy, really before any real amount of chemotherapy is received by the patient, it's important to think about primary prevention through risk factor control, limiting dose, the use of liposomal anthracyclines, which encapsulates the anthracyclines and it's thought to be less cardiotoxic, desoxyribonucleic, as already mentioned, and prognostic heart failure treatment. In the detection of in the preclinical cardiotoxicity phase, it's important to detect it early. Enalapril could be administered or thought of with an increase in troponin or a decrease in GLS of a relative amount of 15%, as mentioned. Further heart failure therapy could be initiated, such as carvedilol. With a decrease in LVEF, but without symptoms, heart failure therapy can be further up-titrated. And certainly if they have overt cardiotoxicity with symptoms, heart failure symptoms, then an addition of diuretics would help to treat symptoms. As mentioned, the esteemed speakers in the series will be touching on these areas in much greater detail, but just here is compared to the traditional thinking of type 1 and type 2 cardiotoxicity, we're seeing here that basically all types of cancer therapies and radiation therapy can have effects on the vasculature, on the valves, on the pericardium, and on the cardiomyocytes. And also to mention that cardio-oncology covers the area of cardiac masses as well. In this fascinating state-of-art review, just published in JACC Cardio-Oncology by Tabelli et al. And it gives quite a very detailed deep dive really into cardiac masses, the differential diagnoses, and also the type of advanced cardiac imaging modalities we can employ, including echocardiography, CMR, schema, which I report clinically as well. It gives additional benefit. It can help to change diagnosis. It can help to assess for perfusion, assess for tissue characterization, or in the one test without any further radiation. CT also is very useful, and positron emission tomography is useful to assess also for, I suppose, glucose avidity of the lesion. A these are the various functions of a cardio-oncology service. I suppose all across the world, cardio-oncology is in different levels of maturity, but certainly a cardio-oncology service can provide monitoring for early cardiotoxicity, secondary prevention of cardiotoxicity, investigation of suspected cardiac invasion by tumor, preoperative assessment for cancer surgery, management of other cardiovascular toxicity like hypertension, and primary prevention of cardiotoxicity in high-risk patients. And of course, in this day and age, no talk goes away without the mentioning of COVID-19. Certainly, there has been very insightful publications on cardio-oncology in the era of COVID-19. More and more data is coming out that cancer patients are significantly more likely to have severe clinical courses in COVID-19, requiring invasive ventilation or resulting in death than compared to patients without cancer. So cardiology, oncology, and cardio-oncology patient populations are at increased risk, not only directly from COVID-19, but also from disruption of their routine care. For instance, in oncology patients not turning up for their chemotherapy regimens, or cardiology patients not turning up despite having central crushing chest pain from a STEMI. Creative ways to address this care gap are essential. To mitigate this risk, the shift to telehealth visits has been a dominant undertaking for many medical specialties. The switch to virtual visits for cardio-oncology practices minimizes hospital and healthcare worker exposures, and multiple societies have also developed guidelines for various investigations, including cardiac imaging during COVID-19, to keep both, the healthcare professional and the patient as safe as possible. Here is a schema on how to approach cardio-oncology in COVID-19 environment, depending on whether we've got low or high case numbers. Obviously, preparation is key, redesigning of workflow, increasing capacity for telemedicine, prioritizing essential cardiac imaging, and obviously preparing for PPE needs, triaging, treatment based on medical urgency and COVID-19 risk, and also important to establish COVID-19 free clinical pathway for patient care and redefine workflow. And obviously in the background, continuous reduction of cardiovascular risk in patients with cancer. And there's also guideline, pathways for risk stratification divided into cardiovascular related risk, cancer related risk, and also COVID-19 related risk. Obviously, in cardiology, we need to triage patients according to their needs. So urgent emergent need would require hospitalization, as does urgent need. In semi-urgent need, as opposed to virtual visits, perhaps face-to-face visits may be more appropriate for better patient assessment. And in low cardiovascular need, then telemedicine and limited cardiovascular imaging at this stage could be tried. Obviously, COVID-19 testing for all cancer patients and close contacts would be advisable if feasible. And in the last few slides, I just thought I'd talk about, the future initiatives in this very exciting and progressive field of cardio-oncology. Myself and Dr. Guha and Dr. Ghosh and other co-authors have tried to, review the topic of cardiac rehabilitation, so exercise as prophylaxis and therapy in cardio-oncology. We have found that, cardiotoxic molecular mechanisms of cancer therapies that have been written about in the literature, including ROS generation, endothelial dysfunction, angiogenesis inhibition, genetic and epigenetic effects, can be mitigated by the beneficial effects of exercise on mitochondria, on anti-inflammation, and on cardiopulmonary effects as well. And we proposed the schema of key foundation strategies, including multidisciplinary approach, adaptive treatment, and regular review to provide towards the four aims of risk factor optimization, mortality reduction, target setting, and motivation and empowerment for cardio-oncology patients, with view to increase cardiorespiratory fitness, improve quality of life, and to decrease fatigue in the new normal, in the new COVID-19 normal, with heavy use of health tech, where we pivot nimbly and we aim to provide home-based treatment with great amounts of self-direction from the patient, also with physician-assisted treatment adjustment. And also in a more, I suppose, basic science field, remote ischemic conditioning, which is, cycles of ischemia reperfusion performed on an organ such as the arm, distant from the heart, that has been found to also have some overlap in terms of its pathways with regards to 5FU dysfunction. It has beneficial effects on endothelial function, on the microvasculature, on mitochondria as well. Also, the sequential phases of 5FU cardiotoxicity with an acute and then later chronic phase can lend themselves as potential targets to dual windows of cardiac protection, which is characteristic of RIC. So to summarize, here's a slide on the various enriched cardio-oncology resources available. Obviously, the Asian Cardio-Oncology Society Conference Series, which is an excellent, brave and ambitious and much needed initiative from Dr. Parikh, Agarwala and colleagues. The International Society of Cardio-Oncology offers international board certification, which I believe is in its second year. The American College of Cardiology has a cardio-oncology section, very useful for fellows or newly graduated fellows like myself to tap into for networking and for collaboration. JAC Cardio-Oncology, obviously everyone knows, is the journal of Cardio-Oncology journal by JAC that has been formed recently. They also have an annual conference. Dr. Ajay Ghosh is also holding European Cardio-Oncology Society courses and courses on cardio-oncology through the British Cardiac Society. Thank you very much again for this generous opportunity. For any collaboration or networking initiatives, please feel free to email me. Thank you.
Thank you very much, June. That was a fantastic exposition, and you really gave us a wonderful idea about the whole landscape of cardio-oncology. There are some very important questions. So can I ask you a few of them, please?
Yes, sure.
So the questions will be shown on the screen, so you can read them also. So Dr. Amishwar has asked, is the GLS part of reporting on 2D echo? Because it is included as part of the guidelines last year.
Yes, thank you. So I did sort of speak to that on the slide, and certainly how we practice in Singapore is by sequential echoes, usually 3 months apart. We would assess for a relative change in GLS of negative 15%. So that's global longitudinal strain. So absolutely, that is part of the definition of cardiotoxicity.
Right. Dr. Vivek Agarwala has asked about the difference between the cardiotoxicity of doxorubicin, which is irreversible, and trastuzumab, which is reversible. So what if the patient is receiving both of them? Would
yes.
Yes,
thank you. I suppose, as a newly graduated fellow, I read about the resources talking about type 1 and type 2, which we now know is, slightly, outdated. So as mentioned, with doxorubicin, the anthracyclines, they actually interrupt topoisomerase beta, which is in the heart. And the HER2 receptors actually spring up in cardiomyocytes as part of a regeneration healing process. So the last thing you need is like a dual hit from the trastuzumab, which blocks it. Right. So yeah, in answer to that question, yeah, the trastuzumab does increase the risk of cardiotoxicity, especially if given sequentially after anthracyclines.
Right. What about TROP-T as a cardiac marker? Do you use it at baseline to pick up early cardiotoxicity, or how frequently do you use?
Yes, certainly in Singapore, we do troponin T and BNP, and also in response to any chest pain or breathlessness. We don't so much tend to in Singapore do it sort of as like a schedule, every third visit. But I'll be keen to hear, I suppose, from other speakers and from other countries what their practice is with regards to biomarkers.
Right, right. So when you set up cardio-oncology for the first time in Singapore, there must have been some teething problems. All of us face that. So what advice do you have to us so that when we set up a new center or a clinic, what should we be, considering in the plan?
Well, I find myself very, very lucky to have been able to pursue cardio-oncology at Bart's Heart Center. Dr. Arjun Ghosh, Dr. Mark Westwood, Dr. Manasty have all been very, very helpful. I often sometimes just text them questions that I need someone with more seniority and experience to answer. And certainly, there are already protocols in place. I found quite interesting coming back to Singapore that the oncologists actually take the lead quite a bit, and they tend to make a diagnosis based on the echo of cardiotoxicity before alerting the doctors, which we've found may not actually be ideal, and that certainly is something that we'll need to work on. Here in Singapore, it's the heart failure doctors that tend to see the bulk of cardio-oncology referrals, but certainly the imaging doctors, because they're able to use cardiac CT and cardiac MRI and echo in multiple different ways to diagnose cardiotoxicity and cardiac masses, they also do take an interest.
Right. Dr. Priya Chudgar, who's a cardiologist from Jupiter Hospital in Thane, is asking, at the follow-up study, do you do it after every cycle of chemo, every other cycle of chemo? What is the interval?
Okay. So we tend to do it every 3 months, but the patients are reviewed before every chemotherapy cycle by the oncologists, but they're reviewed with a routine ECG and symptoms, basically. Yeah, check for heart failure and go from there.
He also has another question. Do you correlate CMR and echo for every cycle?
Yeah. In Singapore, it's a co-pay system. So we tend to go usually with the echo. But certainly if there was any doubt at all based on the echo, particularly if the echo results are read by 2 different people with different results, then we would go with a MRI.
Right. Dr. Rishikesh is asking, what is more important, the absolute reduction or a percentage reduction in the GLS as compared to baseline?
Yes, I believe it's slightly confusing. For myself, I also often need to recap as well. But it's actually a relative reduction of 15%. So say for instance, if say their GLS was 20%, then if you took 15% of that, so that would be like 3%. So if they drop the GLS from like 20 to 14, that would be a relative reduction of 15%. As per the guidelines.
Right. Another question is, can doxorubicin be given infusional over 96 hours to reduce cardiotoxicity? This was something that MD Anderson had suggested.
Yes, I mean, that is something that has also been written about in the literature as opposed to bolus dosing. I guess practically, people have also commented in the literature, to my understanding, that it's not quite as feasible because you end up needing to, I suppose, admit the patient for a longer period of time. I'll be keen to hear from our oncologists as to whether doxorubicin infusion is, just as good for the cancer. Is it just as efficacious against the cancer as opposed to a bolus as well?
This is from our radiation oncologist, Dr. Indu Bansal from Delhi. So, what do you think should be the basic equipment to establish a cardio-oncology center and protocol, especially for pediatric patients?
Oh, wow. So I think, at but they have a late effects clinic and they have a very good, relationship with the pediatric folks with regards to imaging. Speaking from the Singapore experience, our KKH, which is our children's hospital, already have very clear outline protocols. So the patients actually get routine imaging just sort of based on the protocol for monitoring. Yeah.
So between MUGA and 2D echo, which is the one that you would use for a high risk patient for cardiothoracic?
Yeah, I guess it really depends. I guess MUGA would have, radiation. It would also, I would presume, be more expensive for the patient. If the 2D echo is giving results sequentially that is clinically consistent, then I would say it would still, with strain, 2D echo would be quite useful as opposed to giving patients serial MUGAs.
Perfect. So thank you very much. I think we need to move on to the next part of this session. Over to Kavina Creations.
Thank you.
Thank you so much, sir. Thank you, ma'am, for joining us and for the wonderful session. We move over to our panel discussion. Our chairperson for the session is Dr. Parikh, and our moderator is Dr. Senthil Rajappa, medical oncologist from Hyderabad. And his panelists are Dr. Hemant Malhotra, medical oncologist from Jaipur, Dr. Sheila Sawant, internal medicine specialist, Mumbai, Dr. Pankaj Malhotra, hematologist from Chandigarh, Dr. Sinam Singha, cardiologist from Bangalore, Dr. Krishna Prasad, medical oncologist from Bangalore, and Dr. Ashay Karpe, medical oncologist from Mumbai. Over to you, sir. Senthil, sir, are you able to hear me?
You have to unmute. He has to unmute himself.
Done?
Yes,
Yes.
sir. Perfect.
Great. Very good, sir. As usual, keep me warned of the time so that
Of course.
we will live up to our tradition of keeping it up. All right. Great. Okay. So we will get on to our panel discussion. So we'll do two parts, or rather three parts to this panel, 10 minutes each, as I always like to allot some time for everything that we do. We'll start with the preventive aspects, how to go about starting off somebody on a cardiotoxic therapy, how to monitor, and what do you do when ejection fraction starts falling. I think those are the three issues that we will discuss in this panel. So let's start with this case, a 56-year-old lady with stage 3 carcinoma of the breast. She's HER2 positive. At least for this discussion, you have to have somebody who's HER2 positive, ER/PR negative. So I'm not giving anybody a choice of hormonal therapy here. You have to go on trastuzumab. She needs anthracyclines for up to 240 milligrams per meter square, and we'll very soon know why I have put up this number there. And of course, trastuzumab. She's got a history of coronary cardiovascular disease, which was, she had 2 stents in the LAD and RCA about 5 years ago, and is now on some medical therapy. Her left ventricular ejection fraction, which is typically what we do in the oncology clinic for patients who are going on anthracycline, is 58%. So let me start by asking Dr. Hemant Malhotra, sir, what do you do in a situation like this practically? Because we are now, in a cardio-oncology panel, but what is it that happens? We'll go back to your SMS days.
I think, the most important thing here is the most important comment here I'd like to make is that the mind should know and then the eye will see. I remember some 10, 15 years back, one patient, a judge's wife had come to me, similar situation, HER2 positive breast cancer. She was given somehow by one of my colleagues, anthracycline and trastuzumab together. And she had come to me with an ejection fraction of 25%, and she was so dyspneic, grade 4 dyspnea. I had a really tough time in, keeping that judge off the doctor's back. But anyway, the first thing is that everybody should be aware, and I'm happy to say that all the younger medical oncologists are aware what to do now. Before you start the patient, particularly an old patient who has ischemic heart disease, on anthracycline or trastuzumab or both, you have to have a basic cardiac workup. And I think the most easily available cardiac workup is a baseline echocardiogram. I don't think we do any biochemical markers at baseline, but an ECG and a baseline echocardiogram and periodic monitoring of the same as the patient receives anthracycline and as the patient receives trastuzumab, and never to give them together has to be done.
Krishna Prasad, would you routinely send these patients? Let's look at this clinical situation. Would you routinely send this patient to a cardiologist for evaluation, or just like Professor Malhotra said, you would just do it and get on with your treatment?
Yeah, what we do here is if any patient has got a previous cardiac history and we are planning to use cardiotoxic drugs, we would definitely get a cardiologist in the picture, get their opinion, and then only proceed.
Okay. All right. So, Dr. Sheila, what would you do if somebody like this comes to you as part of your initial evaluation?
So, obviously, this patient with stage 3 breast cancer who has underlying CAD will be considered as a high risk for cardiotoxic therapy, be it anthracyclines or trastuzumab. But fortunately for us, this particular patient has already undergone revascularization. He's had a stent in place. So, as a cardio-oncologist, the first foremost thing is to see that his baseline risk factors are well optimized. So his cardiac medications have to be well optimized. We have to see to it that he's on optimal therapy, be it beta blockers, ACE inhibitors, and his antiplatelet agents are taken care of. Patient has to be counseled regarding the continuation of these medications in the times of cancer therapy. So that would be of most importance. And usual practice in any other patient, like we have to always balance the risk of therapy against the benefits, right? So if this patient, if anthracycline-based therapy is deemed essential by the oncologist, then this particular patient probably might require a little more frequent monitoring as against any other patient with no baseline risk factors.
All right, good. So you would go through a proper look at all the risk factors that this patient has, and then make
definitely.
a plan, and then make a plan for your cardiac monitoring.
Exactly. So if this patient has hypertension, I would rather put the patient on a combination of ACE inhibitors. That he has got underlying CAD, I would, if the blood pressure permits, he would be on a beta blockade. So maximal medical therapy would be would be what we would do in this patient.
Pankaj Malhotra, though you're not a breast cancer specialist, since you would be doing anthracyclines with non-Hodgkin's lymphoma, Pankaj, what technique would you routinely use to evaluate ejection fraction? You know, we spoke about 2D echo, and then there's the 3D echo. I really don't know the difference between the 2D and the 3D echo. We'll ask our cardiologists about it. There's MAGA, and then we spoke about GLS. So in the clinic, routinely, what would you use, Pankaj?
So thanks, Senthil. So not only non-Hodgkin lymphoma, even in acute myeloid leukemia also, the anthracyclines are
I don't do hematology anymore, Pankaj, so I forgot about Donner-Rubis in AML. Thank you for reminding me. Go ahead, Pankaj.
Yeah. So and obviously a transplant, bone marrow transplant, is another area where you routinely perform either an echo or more likely an MUGA test before a transplant. So an echocardiography is a routine test which we do in all patients in whom we are giving anthracyclines. Some of our research studies which we have published from PGI, we used to do, even now we do a little infrequently, is to repeat an echocardiography after 4 cycles of R-CHOP chemotherapy to see whether what is happening to the ejection fraction. And in some of our research studies, we have given carvedilol as a prophylaxis to these patients where we feel that they are at high risk of developing.
We'll come to that a little later, Pankaj. We'll just stick to monitoring of LV ejection fraction. So you would use a 2D echo, is that correct?
Yeah, 2D echo mostly, and MAGA in transplant patients.
MAGA in transplant patients. So 2D echo is what you routinely use.
Yes.
Okay, great. Can I ask Dr. Seenam Sinha, what is the difference between a 2D and a 3D echo? Please, pardon me for asking a very elementary question, but this is something that I don't know, so I'm asking you.
No, the 3D echo gives a more accurate numbers of the LV ejection fraction.
Okay.
So unfortunately, till now, all over India, most likely, what we are using is the 2D echo, the simple echocardiography, even for this kind of patients.
Okay, so you're saying a 3D echo is a better test to do, but in most centers you still have a 2D echo.
3D echo and the MRI, cardiac MRI, it gives the more, they give a more accurate numbers. So my idea or my suggestion, like SJ, because we are developing the cardio-oncology department or the forum, so to have at least one 3D echo.
Okay.
Before like going forward with the chemotherapy, like.
All right, you're recommending that we should have a 3D echo to evaluate ejection fraction before going ahead with any potentially cardiotoxic chemotherapy. All right, point very well taken. Dr. Ajay, I put up 3 questions here. So we are all enamored with LV ejection fraction. One thing I keep always thinking is, everybody who walks in for anthracycline, we keep doing an LV ejection fraction. Yes, we do it. We continue to do it and will do it. But how frequently have you really found out somebody with an ejection fraction that's, raising an alarm?
Yeah, so basically, this is a very good question. And in mainly the clinical scenario, it always happens. But especially, I will say, usually you will have some comorbidities like diabetic, they might have, and, you just do echo. There is no apparent history of IHD, but there suddenly the ejection fraction will be 45% or something, or you might pick up. But I will say that is less than in the 5% of the patients where actually you're not even suspecting clinically where any ischemic heart disease or anything will be there. But I think in the terms of predictability of the LVF as a cardiac injury subclinical, I think 2D echo sometimes is more subjective. That is why I believe. I don't know that now we also have on board cardiologist, but who has done the 2D echo, that is the most important thing. And in my patients, at least I see to it that the 2D echo is done by a good cardiologist. Now I'm attached to corporate hospitals, so that is always a privilege, to have a good cardiologist very handy. So I usually, if I'm monitoring, I usually prefer to get a 2D echo by the same person. But again, there is what you can say, there can be a borderline difference, when you are having maybe 45%, 50%, 55%. Whenever we are saying this, I think we are sitting and something like a value of 45%. That is something which is always a borderline. And, really you make it think, are we dealing with any cardiac dysfunction or not? And I think then you might require more sensitive tests.
All right, very good. So we all understand and accept that it's not the best thing to do, but at this point in time, the most practical thing to do would be the LV ejection fraction and monitor this in our patients who are going in for therapy. There are quite a few questions in the chat box on cardiac biomarkers. So the recommendation on some of these cardiac biomarkers is good, but the evidence seems to be low. Dr. Sheila, what would be your comment on doing cardiac biomarkers in a patient whose echo is normal? There's a patient like, what I have put up here with coronary artery disease. What would you, do with a cardiac biomarker that's slightly elevated? And what is that biomarker you're looking at?
No, the biomarker.
Dr. Sheila, please.
Yeah. So there have been a number of studies now with exploring the role of cardiac biomarkers, especially troponin I. The reason being mainly that when we are usually monitoring the patient with the LVEF, it is not a good markup. It is not good because once the LVEF is dropped, it means the patient has already sustained damage. We are looking at something which can detect even before the patient develops a drop in LVEF, right? The reason being that if we are able to identify these patients, we could then think about starting these patients on primary preventive strategies. So as regards troponin I, again, a number of studies have been done. It has been found that it has a predictive role and also a prognostic role. Like especially a number of studies which have been done by Cardinal et al. What they found that patients, the famous ICOS-1 study especially, where they did the troponin prior and after every cycle. And they found that patients who had a persistent elevation in troponin, they had a higher risk of developing cardiac dysfunction, in fact, a major cardiac event in that particular study. And also the response to therapy was poor. As you can see, a patient who did not have an elevation in troponins either before or after. But that is very tedious. Doing a troponin level before and after every cycle is not a practical.
Sorry to interrupt, Dr. Sheila. If I ask you, where would you do it today? Because
I
there's a
would
lot of
do,
data, but we don't know where to place it. I think that's the
that
reason
is the
why I'm
thing. The
asking
current
this
issue is
question.
we really do not know when is the right time. And that is what is the question. Baseline, definitely yes. But how frequently to repeat and at what will be the optimal
So,
strategy is a
so let's
question
say in a
still.
patient like what I put up, if one of the cardiac biomarkers is high, would you look at this a little differently compared to if the biomarker was low? Now this lady has got a CAD, revascularized, ejection fraction is normal as of now. So is there a role in this lady? Let's say if one of the cardiac biomarkers was high, would you put this patient on more treatment or watch this patient more closely compared to somebody
Yes,
else?
definitely.
Okay.
As I already said, this patient we have already tried to put maximum therapy before, but we would try
Right.
and see whether we can optimize further. And also probably we do more frequent monitoring than any other patient, definitely.
Okay, so there are some questions saying,
Yeah,
is
because
it
this is a high risk patient.
so
Probably this is a one patient which we
okay,
can.
okay. Sahu, we'll very soon show you the guideline, what it says. I'm going to show you the guideline a little later. So the other cardiologist, Dr. Sinam, would you quickly tell us what this global longitudinal strain means? Everybody seems to be talking about it, but very few understand what it is. Can you please tell us in short what the GLS is? Dr. Sinam? Or Dr. Sheila, you can take this. Global longitudinal strain.
Yeah, so
what
basically
is it?
this is an index of myocardial deformation. So it is global longitudinal strain. It is basically done by something called a spectral tracking echocardiography, which tracks the movement of the endocardium throughout the systole. We have something called as a circumferential strain and a global longitudinal strain. Most studies have been done on global longitudinal strain. And again, this is found to have a predictive role that a drop in GLS by more than 15%, a patient, the risk of having a drop in LVF down 3 to 6 months is found to be higher. Also, it is like, but even though we detect, it doesn't change the therapy. It doesn't, the oncologist does not change the regimen. Only this patient would probably require more frequent monitoring. And as is also rightly mentioned, it gives us a window of opportunity for cardioprotective intervention. That is the purpose, so that you detect early before the patient sustains damage.
So where would you use it today? If everybody is typing saying that it is part of the guideline,
no, but
most centers don't do it.
No, it is. I agree with you. It is just not practical for us to do it in every patient. The best thing is to risk stratify the patient upfront and then decide a patient who would probably require more frequent monitoring. Those are the patients whom I would insist on having a basal GLS, because doing a GLS later or one single value may not help us. What we need is a basal value. So subsequently, if there is a drop, we know that, yes, we have to maybe add further intervention is required.
Okay, Dr. Pankaj Malhotra and then Professor Hemant Malhotra, both of you, can you tell us, will you use something like this in your daily practice or not? Pankaj?
No.
No, not yet. Professor Malhotra, Hemant Malhotra?
I think maybe if you're doing a research study, but not on a daily monitoring basis. Right?
Okay. So this is the cut paste from the most recent ESMO guideline, the 2019 guideline, which clearly says that GLS, the level of evidence and the grade of recommendation are not very high. So there are people who might want to use it or adopt it, but from a recommendation standpoint, it doesn't seem to be high at all. What it says is that you do a 2D or a 3D echocardiography, highly reproducible quantitative volumetric analysis, and that's what the association or the ESMO at least recommends. So here I have put up the many interventions that you can do. Sahu, you wanted to know about the various interventions here. So I have put up what the grade and level of recommendation for each of this is. So if you look at the markers, it talks about very small numbers, varying risks, varying endpoints, inconsistent results in terms of all of these interventions that I have put up on the left. What about correction of hyperlipidemia? Krishna Prasad, would you be very particular that your patient gets the hyperlipidemia corrected before starting cardiotoxic therapy?
Like I said, if the patient is a known cardiac, had a known cardiac history, then the cardiologist would be in the picture. But someone without a cardiac history, we just get an echocardiogram done and proceed.
I've hardly looked at the lipid levels before.
Okay. So on the chat box, what everybody seems to be thinking is that we should probably start doing GLS. It should be part of routine echo reporting. Dr. Sheila, what is optimal echo reporting for a patient who is going on anthracycline therapy? So Vivek in his introductory remarks mentioned more than a couple of times saying that there should be an optimal reporting. So what is that optimal reporting?
So optimal the basic thing would be to take a complete M-mode measurement, which will give us the dimensions of the heart. The fractional shortening is one important parameter. The wall thickness is important. The LV ejection fraction, what we generally use is the one by the Simpson's biplane or the eyeballing method. GLS, where available and where it is possible to follow only. Otherwise, even in our routine practice, we are not doing it in most patients unless specifically asked for.
Okay.
Yeah, this is what the
okay.
basic
So this is for
is.
basing. So a good left ventricle ejection fraction.
That is most important.
GLS, absolutely agreed.
Because
GLS,
if you have good baseline parameters, then only you could follow it up.
Okay, so there's a lot of Doctor our keynote speaker for today, Madam. Would you what is your final take on GLS? There seems to be a lot of controversy there.
Yes, well, I guess GLS is the most sensitive at the moment. I think I would reserve my comments until the result of the SUCCER trial has come out, where they're using strain parameters to predict, or to direct management and then to predict outcome. I guess until that study has come out, the effect of GLS on survival or on cardiovascular outcomes, with regards to that, I think the jury is still out.
Great. I think you've nailed it perfectly. So guys, there you are, all the chat box. Let's get to the next problem, right? Because she has clearly said that GLS, if you can do it, do it. But clearly what to do with that GLS and how to use it, incorporate into day-to-day practice is not very clear at this point in time. Okay, great. Let's move on. So, so this patient, how frequently would you do the echo, Pankaj, if you were doing anthracyclines?
So for
quick answer, Pankaj. We've got 12 minutes to go. So quick.
Yeah.
Answer.
So yeah. Generally for lymphoma patients, we do after 4 cycles.
You do after 4 cycles, right? How frequently have you really found that somebody's ejection fraction drops after 4 cycles on anthracycline?
In
Pankaj?
our study, in 10-15% patients.
10-15% patients have a drop, right? Because the reason why I asked you that question is, again, as per the ESMO guideline, it says that you do repeat echo during treatment only if you're exceeding doxorubicin of 250 milligrams per meter square, which generally does not happen in breast cancer practice, but probably in non-Hodgkin's lymphoma practice, because 50 per meter square for 6 cycles would reach there. Now, this is for people to know that while on breast cancer therapy, at least routine monitoring while on anthracycline in between. There are people who do it every cycle. There are people who do it every other cycle and so on and so forth. But I think that's not part of the guideline. Biomarkers, again, is a 3C recommendation while on therapy. So that's very poor. We are all very reasonably clear about trastuzumab. So let's go on. After 4 cycles of docetaxel, pertuzumab, trastuzumab, a repeat echo was done, and the ejection fraction dropped from 58 to 46. Ajay, what would you do?
Basically, definitely here I would like to take a cardiology consult. But again, the thing is that I think what we are looking at, are we doing this in the metastatic setting, or are we doing in a
adjuvant setting?
Adjuvant setting.
Yes,
okay.
Adjuvant setting.
So the thing is that, I mean, definitely this case is cornered, like anthracycline.
Good.
So
this is cornered.
yeah, no. So essentially here is, if we really look at it, how there are 2 parts of this. Is it really significant? Because whenever we say 10 to 15% from the baseline, that is what says. So various guidelines have given somewhere like 10 to 15% or less than 45%. So here anthracycline is essentials. Maybe in my practice, I usually do MUGA, check the cardiac function, do the cardiology consult, and if anthracycline is absolutely essential, then usually in these cases, while where the cardiologists clearly say yes, there is a cardiac toxicity, then whether anthracycline can be spared or something of that kind of regimen. Like sometimes we use TC and go ahead with the trastuzumab. I think that will be more essential.
Okay, Dr. Senam, would you let your oncologist use anthracycline in this setting? What would your opinion be if the oncologist throws the ball in your court and says, "Can I use it?" What would you say? I think we've lost Dr. Senam. Dr. Sheila, unfortunately, you
Yeah.
seem to be the single cardiologist on this panel. What
Yeah.
would your
So,
opinion on this situation be?
So as regards anthracycline, we would generally not recommend because the risk of cardiotoxicity will be high. If the patient has to go for further trastuzumab, generally what we do is we ask for get a repeat echocardiography done in a 3 weeks time, and also optimize if the patient is already on cardioprotective treatment, we optimize the dosage. If not, then we start. And if the patient recovers, that is the EF comes up to at least 50% and above, then the patient can be restarted on trastuzumab. But if there is persistent low EF, then the call has to be taken after discussion with the oncologist. There are studies being done now to explore, like the SCHOLAR study and SafeHeart, which is trying to see whether you can, because the aim is to continue as much optimal therapy as is required. So the oncologist takes a call as to how many cycles are over and accordingly decides whether he wants to stop or he feels it should be given more. So those answers are still awaited, but as of now, treat, reassess after 3 weeks, and see what the repeat EF is, and then take it.
Okay, we have Dr. Arjun Ghosh from the UK, who is also a cardiologist on our audience. So Dr. Arjun, would you take that question? Can anthracycline be started if the EF falls to less than 50, and this is nearly a 12% drop in the EF? What would be your opinion?
I'm trying to unmute him.
Okay.
Arjun, can you unmute yourself, please?
Dr. Ghosh?
He is not unmuted.
Okay, Krishna Prasad, what would you do, Krishna Prasad? Would you be happy to continue anthracycline with all the cardiac drugs on, or you would say, I want to stop it, I don't want to use anthracycline anymore?
Yeah, in this patient, we have given 4 cycles of docetaxel, pertuzumab, trastuzumab. I would be keen to just give the 5th cycle of docetaxel, eliminate both the anti-HER2 agents, reassess after 3 weeks, and then take it forward. Just like the cardiologist said, if the improvement is there, then maybe we can reintroduce, because there is a concept that we can reintroduce anti-HER2 agents. But if the ejection fraction doesn't improve, anyway, 2 more cycles, I would just give docetaxel, then proceed with surgery, and then forward. I would not use anthracyclines.
You would not use. Professor Malhotra, would you use anthracyclines in this patient?
No, I don't think I would.
Okay.
Of course, I would, pass on the buck to the cardiologist, take his opinion here, his or her opinion. But I would be very reluctant to use anthracyclines. And I think we have several quite effective non-anthracycline drugs.
Agreed.
Which are considered.
Absolutely, absolutely. So I would also do similarly to what all of you have said, but there seems to be a place for using anthracycline even in a clinical situation like this. Again, this is from the ESMO guideline. It says that if your ejection fraction is more than 40, but less than 50, you can use anthracycline in a setting like this if you don't have any other choices, but with alternate cycle monitoring, very, very close monitoring. And I think all of our panelists were absolutely right on the trastuzumab issue, that you put them on cardiac measures and then reevaluate the ejection fraction in 3 to 6 weeks. And then what would you do, Professor Malhotra, if the ejection fraction does not improve? And in this patient, we are now stopping anthracycline. We are not going to be able to use trastuzumab also, if you say so. But what would your opinion be on continuing trastuzumab in a situation like this?
I think again, monitoring you have to kind of weigh the potential irreversible cardiotoxicity with the chance of the malignancy coming back, and of course have the patient
stage three.
Yeah, and have the patient on board, have the cardiologist on board, and then you can every 2 cycles monitor the cardiac function, monitor the cardiac enzymes, and with full cardiac protection. Try and continue, and if there is further drop in ejection fraction, then you certainly don't continue the
Very good. I think that's a very important point. So it does not mean that these drugs are absolutely contraindicated. I think, as rightly pointed out, you have to weigh the risk versus benefit of any such intervention which continues to potentially affect the heart. And if you think that the benefit of the drug is, if the benefit of drug is going to be much more than the cardiac compromise that it is likely to cause, then I think it's fine to go ahead with the drug. But if it's the other way around, if you have an alternative that is not cardiotoxic, it's better to use that rather than continue a drug like this. And I don't know of a drug, anti-HER2 drug, that is not cardiotoxic. And that's what is on this guideline algorithm from the ESMO again, that if you have a drop that's less than 10 to more than 50, continue the cancer treatment. But if your LV ejection fraction decrease is more than 10% and drops to less than 50, it's important to temporarily withhold that cancer treatment and put them on full cardiac measures to make sure that you're doing your best to get that up. And then at the end of that, if your ejection fraction improves, then it's okay to go ahead with it. I think that this kind of summarizes. So let's say Hemant, Pankaj Malhotra. So I keep getting confused between the two Malhotras on the panel today, I suppose. Pankaj, somebody has an ejection fraction of less than 40. Would this patient, let's say with AML, have you got alternative therapies for this patient today?
Yes. So yes, if somebody has ejection fraction which is less than 40%, then obviously I'm going to avoid anthracyclines or cardiotoxic agents. We have to consider alternate chemotherapy.
Okay. So Amish has put up a question there saying adjuvant trastuzumab, certain centers allow asymptomatic drop up to 40% also. Any comments from any of the panelists? Dr. Sheila, would you want to take that before I conclude?
Yeah, there are certain centers where they do consider. This is absolutely on a case-to-case basis.
Right.
You try to give maximal medical therapy and see as to how many more cycles you can give, provided that the patient doesn't develop symptomatic heart failure or a significant drop in EF. So this is absolutely on a case-to-case basis.
All right. So let me quickly summarize this. This is the algorithm from the ESMO's guideline. So if it's less than 40, cardioprotective therapy first. Consider first-line cancer therapy without cardiotoxic drugs ideally, and use the second-line treatments. Of course, you have to get the cardiologist in early. If it's less than 40 to, less than 40 or 50, then consider alternative treatments. Of course, again, cardioprotective therapy is important, and then you can start your anti-cancer therapy. So I think 50% seems to be a magic number there. If anything drops to less than 50%, it's very important to look at the risk versus benefit of any potentially cardiotoxic therapy. And if you see that the risk of the therapy is much more than the benefit of the therapy, obviously you should not continue it. But if the benefit seems to be higher than the risk, then it's perfectly all right to continue a cardiac therapy, potentially cardiotoxic therapy, even if your ejection fraction falls to less than 50. So I think there's a lot of evidence that needs to be generated in this space. That's very evident whenever you read a guideline, because except your LV ejection fraction, about which all of us are reasonably sure about, all the other parameters seem to be a 2 or a B or a C3 recommendation. So I hope the association that's formed today will get some data together and generate some evidence to give us more data on how to go about managing all of these patients. So that's evidence-based medicine and evidence-based ignorance. I thank all of you for giving us this opportunity, and great all panelists for putting up your answers in the face of very minimal evidence that we have in this particular situation. Thanks so much, and let me hand it over back to the organizers.
Thank you very much, Senthil. We have a few questions from the audience, so they will be shown on the screen, and then you can either answer or ask one of your panelists. Please go ahead.
Okay, so for a patient with history of acute myocardial infarction, ejection fraction above 50, any contraindication for anthracycline or trastuzumab? I think we've discussed this, Sahu, that if the ejection fraction is above 50, it's perfectly all right to start, but make sure you're controlling the risk factors, make sure you're getting an early cardiology input. The marker may be something that you may consider doing in a situation like this, but it's not a contraindication. Which is preferred, baseline ECG or echo? I think Amish has got a full session on 5FU. So can we pass this question to Amish a little later?
Sure.
What is the scientific recommendation once a patient develops cardiomyopathy with a certain regimen? I think we need to get to the cardiologist for that. Madam, Dr. Sheila, would you like to take that question? How would you manage a drug-induced cardiomyopathy is what?
Yeah, so basically, whatever the current guidelines mention is we use the anti-failure treatment which has been established for the general population, because there are no specific studies for management of cardiac failure in the oncology setting. So the usual neurohormonal blockade, JIT balls, ACE inhibitors, ARBs, beta blockers, and diuretics is what forms the backbone of management of these patients.
Okay, right.
Yeah.
Tarini Prasad has asked a question and also a comment. Baseline, definitely yes for biomarkers. Is it mandatory? I think again we answered that question, Sahu. It's a 3C recommendation. So Madam also rightly pointed out that we are not too sure what elevation is important, when to do, how to monitor, and what is the most optimal intervention. Dr. Purna Kurkure has asked, when you are combining anthracycline with radiotherapy, how do you monitor toxicity? Dr. Sheila, would you like to?
Again, echocardiography is the as regards monitoring, the objectively monitoring cardiac function, echocardiography is the method which is used. But in patients who have received, those who have received mediastinal RT, again, coronary artery disease is a significant concern. So a good clinical history will be very important, because radiotherapy related coronary artery disease may not present in the first few years. It takes many years to develop. So a good clinical history would be equally important. And echocardiography, as we do for anthracyclines, it's only on symptom based, because generally we do not, for long-term surveillance, there are no definite recommendations for a routine echocardiogram. But baseline, yes.
Good. Can I take a couple of questions from the chat box, sir? Is there time?
Yes, please.
Can the same chemo regimen be restarted after the left ventricular ejection fraction has improved to normal levels? Yes, the answer is yes, but with closer monitoring. I think that's very important to keep in mind. In adjuvant setting with decreasing LVEF, is it prudent to delay radiotherapy, especially in a left-sided breast, to wait for LVEF improvement? I think that would be prudent, but I don't know whether there is high quality evidence to say that delaying radiotherapy is likely to be beneficial. It depends upon how quickly or lately the heart will recover from the insult because of the cardiotoxic medical therapy that we have done. So I'm not too sure there is a perfect answer to that. Should we consider for cardioprotective agents if the ejection fraction is just above 50, like 50 to 55, especially in the elderly, as it's expected to decrease? The answer is yes from a judgmental standpoint, but when you look at the guideline says that the grade of recommendation or the level of evidence for that is not very high. But I very much agree that this is a patient who typically should be subject to an early cardiac evaluation and put on drugs to make sure that there's as much protection as possible before the start of your cardiotoxic therapy itself. So it'll be a good idea to do that in consultation with the cardiologist itself there. I think there are no more questions. So very important early cardiac inputs. LVF seems to be the gold standard, but GLS seems to be making some inroads. We don't know where to use cardiac biomarkers as of now. So again, that's something that we will wait to hear more about, and weigh the risk versus benefit of any intervention that you're using, especially in a patient whose cardiac function is dropping. Thanks all of you, and I hand it over back to the organizers. Thank you so much for the opportunity.
Thank you, Senthil, and all the panelists for this excellent job. I think the interaction was so intense that most of the questions have been answered, or we have found that there is no real level 1 evidence at present. I hand it over back to the organizers for the next session.
Thank you so much, sir. Now we'll move on to the case presentation. Our chairperson for the session is Dr. Jun Hua Chong from Singapore. Thank you so much, ma'am, for agreeing to chair the session. Our case presenter for the session is Dr. Amish Vora, medical oncologist from New Delhi.
Can you share my presentation?
Yes, sir.
Please.
Yes, sir.
Thank you, everyone. Next slide, please. In fact, this case, I was so desperate to present when Dr. Purvish Parikh called me that, do you have any interest in cardio-oncology?
Miss, you are not audible to all of us.
Am I audible now?
No, no, no.
Sir, you're audible. Amit, sir, can I request you to increase the volume? Amit, sir, please go ahead.
Okay. So when Dr. Parikh called me, I was doffing off PPE and I told sir, wait, sir. Please don't, please give me this opportunity because I want to present this case. Next slide, please. There were two reasons and I will share those two reasons why I wanted to present this case. All of us have seen all types of 5FU induced toxicity, including myself. Today, we are talking specifically of cardiotoxicity. Next slide, please. 53-year-old male, CA colon, in past partial pneumonectomy done 8 years back, operated in early 2019 for colon cancer, P-T3N2. The first interesting point comes here. The treating surgical oncologist refused to offer chemotherapy to patient, saying that you will not tolerate chemotherapy. Patient did not go to any medical oncologist. 8 months later, presented with intestinal obstruction, emergency surgery done, metastatic disease in abdomen. Next slide, please. KRAS, MSI both done, RAS wild type, MS stable, counseled for FOLFOX, patient agreed. 2D echo, ECG, TROP, everything being done because patient surgical onco told you may not tolerate chemotherapy. Patient was found absolutely fit for chemo, chemoport insertion done. FOLFOX started in early March before lockdown. Next slide, please. 12 hours after starting 5FU infusion, this is classical history of cardiotoxicity. 6 a.m. in the morning, patient complained of chest heaviness. ECG done, duty doctor seen, infusion stopped. Patient felt better. 10 a.m., again some chest heaviness, ECG done again, T wave changes, trop negative, echo LVEF 50%. Next slide, please. Patient shifted to cardiac CCU. Vitals were okay till that time, till tachycardia. Extremities cold and profuse sweating started. 12 noon, echo ejection fraction dropped to 35%. Standard cardiac treatment started. 2 p.m., the BP was 60 systolic, high dose of ionotropes, cold clammy extremities, no urine, still profuse sweatingly. 2:30 p.m., prognosis was explained to family that we may lose patient because of this. In fact, 2:45 p.m., ejection fraction further dropped to 20%. Next slide, please. This is the antidote, but it was not available. Next slide, please. And it had to be given within 96 hours. Again, from UK, it would have taken more than that. Next slide, please. I desperately called Dr. Ashok Vaid, sir, and said, sir, this is the scene. And I remember Dr. Vaid said, Amish, this patient will walk home. Don't give up. I took a U-turn, went to the cardiologist office. We both went to CCU, counseled patient regarding IABP. Next slide, please. Intra-aortic balloon therapy aids cardiogenic shock patients. This is what the article said. Next slide, please. 5 p.m. IABP done. 6:30 p.m. sweating reduced. BP holding up at 70 systolic. Extremity still closed. 8 p.m. BP systolic 90, pulse 100. 10 p.m. BP normal, pulse 94. Road to recovery. Next slide. Patient didn't look back. Better and better. Ejection fraction started improving. Urine output improving. Patient fine. Next slide. All okay. After 2 days, IABP removed. Still patient okay. Shifted to ward. Finally, at the time of discharge, I remembered Dr. Ashok Vaid sir's words. Amish, this patient will walk home. Next slide, please. If you see in the blue, it is difficult to see at the time of discharge, Mr. So-and-so is able to walk into the corridor without any complaint, without any breathlessness. Next slide, please. Cardiac failure with 5FU, 8.5% is incidence, 0.55 is reported incidence of heart failure, case reports of cardiogenic shock, and probably this is the first reported or presented case of intra-aortic balloon pump placement in India. Next slide, please. Intra-aortic balloon placement, what is its role and what happened in this patient? I hand over to my cardiology expert, Dr. Vinayak Agarwal, who is a cardiology colleague in PSRI hospital where I work. In fact, he's the first person who introduced the concept of GLS in me. Over to Vinayak, sir.
Thank you, Dr. Amish, for this opportunity, and I thank the organizers as well. I'm going to share my screen and take you through the case. Dr. Amish has already given you a head start about the case and how it went about, but I thought it will be nice to just share, subtle important issues when the patient like this comes to you, who's been given 5FU. So if you see, he came to us on 5th March, and this was the first ECG when he actually started complaining of chest pain. There was some subtle STT changes, slight ST elevation in V1, V2, V3, but nothing really significant. This is the 6th, the similar changes. When I did the echo, we actually found the ejection fraction, which had gone down to 35%. We do global longitudinal strain in all our patients, so it was markedly reduced. Please remember that the normal GLS is somewhere around minus 19% or so, about 19 to 22% is what we take as normal. GLS was markedly reduced in this patient. LV was dilated. There was mild mitral regurgitation. PA pressures were 40. So we went about, and this was the echo. I know that a lot of people don't know how to see the echo, but this black is the blood, and this is your left ventricle, mitral valve, aortic valve, left atrium. You can very well see the en-face view of the left ventricle contracting much less. This was the 4-chamber view. You can see that the LV is dilated. There was overall dilatation of the LV, contractility was much less, and there was significant mitral regurgitation, about mild to moderate regurgitation with diastolic and systolic dysfunction both. Then when we did the GLS, you can see that the GLS looks like this, global longitudinal strain. We can take out a map like this, which is known as the bullseye, and it was markedly reduced at minus 10.6%. So as Dr. Amish has already told you that we initially tried to, take the patient on medical therapy, but he deteriorated very fast, was on norepinephrine, and then the ejection fraction fell down further to 20%. I deployed the IVP on the second day itself on 7th. The patient started to show some recovery. The ECG changes started to change. There was actually, ST inversions in the anterior leads. And then on the 9th, that is 4 days later, the ejection fraction resurfaced to 30-35%, started improving. We took out the IVP on 11th, and you can see that the ECG is normalizing on the 12th. And the echo, which we did on the 12th, shows very well recovered left ventricular function. You can see that the contractility has improved. And the GLS also showed improvement to minus 12% or so. So you can see the ejection fraction is 60% now, and the GLS is also improving, though not to the normal levels. The troponins showed definite rise to 0.2 nanogram per ml. So coming to 5FU cardiotoxicity, it is a potential severe side effect of 5FU and the second most common after the anthracycline toxicity to the heart. And these patients usually present with chest pain, which is secondary to coronary vasospasm, can actually be MI also, but then they can have dilated cardiomyopathy, ventricular arrhythmias, or even sudden cardiac death. And they can have various tachycardias, can have various ventricular arrhythmias, QT prolongation, and coronary dissection as well has been reported. The reported incidence of cardiotoxicity is actually very variable. It has been reported from 1 to 18%, and that may be because we take different risk profiles in different study populations, and we also the different administrative schedules. But we do know that the patients who have concurrent chest wall radiation therapy, multi-agent chemos, and pre-existing CAD, structural heart disease, and cardiomyopathy are more prone to develop 5FU toxicity. So, but if you look at the comorbidities like diabetes, hypertension, dyslipidemias, they are not directly implicated in the risk of cardiotoxicity secondary to 5FU. What is very important is that the bolus is actually safer, remarkably safer than the continuous protracted infusion. which has shown cardiotoxicity as high as 18% versus a bolus, which is less than 3% cardiotoxicity. The mechanism of 5-FU can be varied, can be direct cellular damage or ischemic, coronary vasospasm, endothelial damage, can be Takotsubo like. So these have been proposed in various studies. So the treatment remains simple. Immediately abort the chemotherapy. There are anecdotal or there are studies which have shown a benefit with diltiazem, nifedipine, and nitrates. But please remember that our patient had hypotension going up to 60 millimeter of systolic. So there is no way you can use these drugs in certain situations. Uridine triacetate, as Dr. Amish said, was not available. So we had to put IIBP in this patient, which showed remarkable improvement over the next 3 days. We do know that the re-challenge, if you do with 5-FU in these patients, can have a recurrence of cardiotoxicity in almost 90% patients and death in 13% patients. So you have to be very careful in re-challenging them with 5-FU. Already there was a lot of discussion going on about GLS and the cancer therapy-related cardiac dysfunction, but by definition, I think if there is a decrease of LVEF of more than 10% with EF going below 53%. So I am quoting ASE 2014 guidelines and later on the updated ones. So this is important, the fall of EF. We know that EF is a very loose kind of, not a very accurate assessment of LV dysfunction, especially those who are doing GLS. So we do see a temporal variability in EF of up to 6% when you're not using non-contrast 3D, but it is variability is up to almost 10% with 2D echo. So GLS is actually something which should become part of your repertoire very, very quickly if it is not yet. And you can see that the anthracycline toxicity, which was discussed in the previous case, has already shown that GLS is a very important component of determining an early toxicity with anthracyclines. And what we define LV dysfunction is a drop of 10% to below EF of 53% or below, which somebody was saying is 50%, which is fine. But GLS, we say if it is less than 8% drop, then we say that there is no subclinical LV dysfunction. But if it is more than 15%, there is subclinical LV dysfunction, and these patients should be very carefully worked up on chemotherapy. Succor trial, as was already mentioned, is awaited, and this will actually give us a lot of information about the role of GLS in cardio-oncology. Thank you.
Thank you so much, sir. Okay, over to you, Kashish.
Thank you so much, sir. Sorry to interrupt you. I now request Dr. Amit Joshi, medical oncologist from Mumbai, to please give the oncology overview. Amit sir, are you able to hear us?
Yeah, Amit, please go ahead.
Yes, sir. So I think, can you hear us, sir?
Yes, yes, go ahead.
My slides are seen.
Yes.
So, yeah. So I think, first of all, I would like to thank Vivek and Dr. Purvish, sir. This is a very, very important topic and mostly neglected in our OPD, and we all use our personal experience sometimes. So I think it's a very important thing which you have taken, and definitely we will go ahead with some good data in future. So just my thought on what we do in practice when we consider 5-FU related vasospasm. So I think that has been described by Dr. Vinayak already. The incidence ranges from 1 to 20%, but on an average it's around 8% as the definition of all these varies. So risk factor, as already discussed, the older age, the concomitant use of cisplatin and oxaliplatin further increases the risk. And other thing is the relationship with DPD mutation is not very clear as it is with the mucositis and bone marrow suppression. So that is one another thing which we should know. So I think, as already discussed, the chest pain, which can be so. The most important thing about the 5-FU related cardiac toxicity is that the chest pain may be non-specific, and it may or may not associated with ECG changes. Sometimes when patient tells us the discomfort, we do a ECG and we find it normal. So, but we should be aware in the mind that this may be normal at this point of time, but this may be abnormal at certain. So other thing is that what we have seen, this is one of the very common symptom which may not common, but this symptom should be looked suspicious in patients who are having 5FU gastritis like symptom, because the patient are taking other drugs also, dexamethasone for prevention of nausea and vomiting. So we sometimes feel that this symptom might be related to the steroid use, but you have to be a little bit careful if patient complaining of gastritis which is not relieving with the usual antacid or H2 blocker or PPI blocker. So you have to be a little bit careful. And the other thing is that less common thing which we have seen are the palpitation, dyspnea, diffuse pleuritic pain. So what I meant that any unusual symptom in a patient which is receiving 5FU definitely requires an investigation and close monitoring. So don't avoid the symptom. So if patient is because they might not be able to complain what the actual symptom. So if you are not feeling well about the patient is complaining some uneasiness, you have to be a little bit careful. But rarely you can have as discussed, supraventricular arrhythmia, bradycardia, ventricular fibrillation, and the most important thing that in patients who develop this toxicity, the mortality can range from 2 to 13%. So we have to be a little bit careful with this thing, and we should not ignore. So the summary is that we should not ignore the unusual symptom. If the patient is complaining of chest pain, definitely we will evaluate, but don't ignore other symptoms which may be related to this thing. So as discussed, the ECG lacks the sensitivity. So if the ECG is abnormal, it's okay, but if it is not, if it is normal, you can't rule out. You have to keep a close watch. So as discussed, the most common ECG finding may be STT deviation. Arrhythmias can be seen in around 20% patient. ECG may reveal global kinesia, but can be normal also. And the assessment of coronary arteries might not need, as discussed, the most important pathophysiology is the coronary vessel spasm. So this may not reveal anything. So the other thing is on the management part, which we have learned over the time, that before, and this is very important for all of practicing oncologists, that before planning a DCF-based chemotherapy, at least in head and neck cancer, where the 5FU dose is still more and is a 5-day infusion, we have to discuss with the family regarding this rare possibility of this toxicity, which may be sometimes rarely life-threatening. So we should have at least some sort of discussion that it is unpredictable, and this may be in a very, very rare situation which we can't predict, but this can be a life-threatening. So some discussion should be there, and that should be recorded that we have discussed this issue with the family and patient before starting the 5FU-based, at least the infusional therapy. And definitely the stopping the infusion is the first thing which we do. Calcium channel blocker may help, and nitroglycerin in some refractory cases may have helped. As discussed, the 5 re-challenge is very controversial. At least in our practice, we do not go for re-challenge if any patient develop any sort of cardiotoxicity. Prophylactic with the nitrate or calcium channel blocker are not effective, so and it's not indicated. And so in general, the re-challenge may be successful, but is not recommended in more than 95% of the patient. Dose reduction. So if you feel that if you reduce the dose, so dose reduction is also not an effective means of mitigating the fluoropyrimidine induced toxicity. So if either it should be given or it should not be given. So dose reduction has not helped. And the prophylaxis, as discussed previously, there is no such data and no such trial which shows that prophylaxis may help. So it's not going to help giving calcium channel blocker or nitrate prophylactically and preventing the toxicity of this. The other thing which is important is that the Tegafar uracil combination comes with the UFT name. This has in the literature has shown less toxicity compared to the 5FU. If we are compelled to use the 5FU and cost is not a constraint, this can be considered as one of the alternative. But it's always better to use other class of drug rather than the fluoropyrimidine. But UFT can be an alternative in some affording patient where we are compelled to use this. So take home message. Coronary vasospasm is not less common. In fact, it is common with 5FU use. So in our practice is around 8%. In few cases, this can present as a sudden cardiac death. Proper patient selection is very important. So as discussed, avoid using in patient with pre-existing cardiac problem. Baseline echo and ECG definitely helps in selecting the patient. first cycle of 5FU is very, very important. So what we do in our practice, that when we start the 5FU first cycle, we attach the cardiac monitor, we instruct the sisters there and doctor on the duty. If there is any rate change in the rate, if there is a bradycardia less than 60, any abnormal rhythm, we have to inform, and then we will take a decision regarding the stopping of therapy. So with this continuous monitoring of for 5 days in a first cycle is little bit tedious, but definitely it helps. And with this use, we have successfully averted the complication in few of the patient. As they started bradycardia, we stopped the infusion, and ultimately they recovered. So I think that is one thing which we have. So the instruction to the supportive staff, nurse involved about immediate report of any new onset chest pain, palpitation, perspiration, retrosternal burning, giddiness should be stopped, and the 5 years should be stopped if the heart rate goes below 50 or new.
I think I can't hear Amit anymore.
Electrolyte in this scenario, and as discussed, the informed consent should be given, and the most important, as the previous case was discussed, have a good cardiologist friend in your team, like the Amit sir has successfully treated that patient. So we should have a very close consultation with our cardio-oncology colleague regarding this, and proper patient selection is the most important key. Thank you.
Thank you very much, Amit. And over to our chairperson to moderate the question answer.
Thank you, Dr. Agarwala and Dr. Vora and team for this very insightful talk. I'll start with the first question from Dr. Iqbal. Any role of ISMN before Philfox?
So I think I'll take that question because I'm the cardiologist here. So there are some reports where they've said that if you, so there are no reports which say that you can preemptively give any drug like ISMN or say diltiazem to prevent coronary vasospasm later on. I mean, there have been some people who have used it, but most of us, there are no hard trials to actually support that data, number one. Number two, they do say that if the patient starts to show chest pain very early on in the infusion of 5FU, then if you give symptomatic treatment in the form of nitrates, diltiazem, then about 69% of these patients may actually show reversal of the chest pain. But if you, I feel that if you don't monitor them very carefully about the progression of toxicity, then we may land up in trouble because symptoms may be very, very subtle, may actually be absent while the cardiotoxicity is progressing.
Yes, thank you. Yes, indeed, it can.
Just to add to what
yes.
Dr. Agarwala sir has said.
Sure.
So in 5FU, especially cardiotoxicity, what I have learned over the years, take every symptom very seriously. Even if all the investigations are normal, and if you strongly believe clinically patient can have cardiotoxicity, please do not ignore it. Stop 5FU infusion, wait for some time, confirm with your cardiologist, only then restart. That is what I have learned. Yeah.
Yeah, it can be very insidious indeed. Thank you. We'll move on to the next question from Dr. Gautam. What about coronary angiogram in this patient?
Yeah, I think that's a fair question here. I think if the patient had not improved so quickly as he did, so let us assume for a while that this patient actually had a large anterior wall infarct. One, the ECG really wasn't supporting that diagnosis. The other possibility was stress cardiomyopathy in these patients. The enzyme rise was from say normal of 0.04 was about 0.2. The patient did not have severe chest pain. The patient responded extremely well to IABP insertion and actually improved very quickly. If he hadn't improved, I'm sure I would have taken him for a coronary angiogram to rule out, underlying MI.
Thank you. I might just sneak in a question there because you've clearly highlighted the importance of strain. I was just wondering, with the strain pattern in this patient, did it suggest any regionality to it as a culprit lesion in a vessel, for instance?
So if you remember the bullseye that I showed, it was actually quite a diffuse myocardial dysfunction. Even the LV ejection fraction was globally reduced. There was no regionality to it. But we do know that regionality doesn't really mean an MI. Sometimes you can have regional dysfunction even in a cardiomyopathic situation where septum may be more involved than the lateral wall or whatever in any of the patterns. So regionality can give you a clue, but it's not a hard and fast rule about pointing towards an MI. I think you have to look at the clinical picture, the ECG, the enzyme rise, keep a possibility of acute coronary syndrome. And if the patient doesn't improve, then yes, of course, you have to take them for angiogram and intervention. I think it would be fair to say that this patient could have been taken for an angiogram, but please remember that logistics as well as finances are also very, very important in a lot of these patients. So some of them may not agree to interventions at all times. Like in our country, it's very common. In fact, this patient was not he was a personal cash paying patient. He did not have any insurance. So you have to be a little, careful about the expenditure as well.
Yes, and I guess it really depends on whether there's anything you can do about it as well. I mean, you're not really expecting to find a plaque rupture, which I suppose leads us on to the next question from Dr. Vivek Agarwala, how to really assess that there is atherosclerotic event or spasm. MI can happen too.
So yeah, I think it's a related question. What I feel is that coronary vasospasm usually presents exactly like an ST elevation MI. Okay, there would be a hyperacute T wave changes. You would have an ST elevation. Patient would have significant chest pain for at least 15 to 20 minutes. What we saw in this patient was a mild, ache initially, and there were slight ST elevation, not significant up to 1 millimeter or more. There was, subtle changes which were happening in the ECG. The troponin rise initial troponin was actually negative, and then after a couple of days, it went up to 0.2. So I think in these cases, I would have felt that it could either have been a stress cardiomyopathy-like situation, or maybe a cardiomyopathy, acute cardiotoxicity or cardiomyopathy in this patient, rather than a coronary vasospasm per se, though it could have been.
Thank you. And a question from Dr. Skaya. Should a patient who develops severe cardiomyopathy with 5FU be re-challenged with the same regimen once EF is improved to normal?
So I think we have already answered this. Dr. Amit very nicely showed, I also mentioned that when you re-challenge these patients with 5FU, there is a 90% chance of recurrence of cardiotoxicity and 13% risk of death. So I think unless you really, your back is against the wall, I wouldn't really recommend re-challenging with 5FU.
What Dr. Vinayak has said is absolutely correct. The guidelines mention grade 1, 2 and routine monitoring. You can re-challenge if there is some issue. Grade 3, 4, especially severe cardiomyopathy, cardiac failure, cardiogenic shock, it is recommended not to re-challenge patients with 5FU. That is what majority of the guidelines believe.
Thank you. And this is a question from yourself, Dr. Vora. DPD enzyme level, should it be done in or before starting? And cardiac monitoring throughout is a problem. 50% will show some changes. So any comments there, please?
No, this question was for Dr. Amit Joshi.
So, Amis, what I can, whatever little experience I had, actually, in fact, everyone had burned in the life with 5FU. So after starting with this close monitoring, what I observed that if the bradycardia starts, so you are on guard that now the patient may have some problem. So with this close monitoring, at least we have stopped the infusion when the heart rate approaches around 50, 54. And if there any abnormal symptom seen in the ECG, I stop. So it may not be possible, but it can be considered in a ward also. You can attach the monitor and see. So it's better than nothing. That, but I can say, just keeping the patient without a monitor, it may be helpful. I'm not saying that it will help, but it may help. At least it can prevent those few complications in the practice. And regarding the DPT, if you ask me, I think in the current era, we have to do a DPT mutation medico-legally also. The only question comes with the first cycle, it's a little bit difficult because it takes time. So definitely we send the sample, we start the 5FU, and if the reports come, it shows heterozygous or homozygous, then we modify accordingly. But I think if in the due course of time, if any techniques comes which we can detect by urine or something, if we can detect early, it's always better to have before starting the therapy. At least other complications we can also prevent, like the mucositis, diarrhea, and the bone marrow suppression with DPT.
Thank you. And the next question is from Dr. Agarwala about starting aspirin, clopidogrel, atorvastatin, MI protocol until it's confirmed that it's not a plaque rupture.
So I think it's fair to actually start if there are no contraindications in these patients. At least aspirin and atorvastatin can definitely be started in these patients. The only thing is that I think if you are suspecting acute coronary syndrome, then dual antiplatelet therapy and high dose statins are something which you should give according to your clinical assessment. And in most of such cases, in fact, we would do a very quick check angiogram to rule out coronary artery disease. Yeah.
Okay. And next is a costing issue. What is the cost of IABP?
So cost of IABP is somewhere in Indian rupees, somewhere between 70,000 to 90,000 rupees is the cost. And then the daily cost of that, because the patients remain in the ICU, they are on heparin infusion, and they require a perfusionist as well as a whole cardiology setup. So it is an expensive proposition. You would probably be spending about 25,000 a day on ICU charges every day, and of course the initial cost would be around approximately 80,000 or so Indian rupees.
Yes, so that's quite a costly endeavor. And how to differentiate between coronary vasospasm and MI in acute phase. I believe this has been touched on, but yeah.
Yeah.
Thank you very much, Jun. Dr. Vinayak, Dr. Ameshwara, Dr. Amit Joshi. In fact, Amit, when you were talking about symptoms of IFU, this was one of the few times when I saw you smiling on webinar. It was so nice to see you. I thank all the other faculty as well. We've had a wonderful and intense discussion, and we invite you to continue with our Thursday evening webinars, and please participate in that. Over to Vivek Agarwal for final comments.
So I think, sir, we have had a very fruitful discussion today. Thank you again to all the faculties involved today, as well as to all the participants. I think we touched upon some really nice topics, and something different from what we were actually discussing in the past few months. Something a different discussion. I think I have really had wonderful comments from everybody regarding encouragement. Again, thank you, everybody. And as you said, sir, I invite you, everybody, to join our Asian Cardio-Oncology Society. The membership forms and links are shared in the chat box. And please continue to log in every Thursday at 7 p.m. till 5th of November. Thanks again, and good night.
Good night. Thank you.
Good night.
On behalf of the Asian Cardio-Oncology Society, I would also like to thank our supporters, Intas Oncology, South Asian Journal of Cancer, Indian Cooperative Oncology Network, and the Integrated Academic Society of Clinical Oncology. And also to let our participants know that the login details will be the same for all the rest of the 6 meetings. Thank you, everyone. Good night.
Good night. Thank you.